What we know very clearly about low back pain is it's very common and it's very costly in our westernised societies. Nearly all of us will get low back pain at some point in our lives, around 80% I think is the estimate.
The traditional diagnostic approach to trying to differentiate patients, to decide which patients can we give confidence to self-manage and which patients do we need to give that extra little bit of help to, hasn't really been working. It's not been systematic enough in helping us to identify the patients that end up with all serious problems and those that get better themselves.
So the challenge is that we don't know which patients to offer which treatments to.
And what's done at the moment in primary care practice is it's left to clinical intuition to decide, okay, which patients do we give that extra help to and which patients can self-manage. And so I guess what we're trying to do with the research that we're doing here is saying, can we be a bit more systematic about trying to work out which patient goes where, and can we be more efficient so that we're not missing the people that really are going to end up with serious problems, and we're not over-treating people who are going to get better anyway.
So again, what we're trying to identify are better ways to match the right patients to the right treatments.
The way that we're using our new approach, the new Start Back approach, is that when a patient comes to see their doctor or a physiotherapist with an episode of back pain, we ask them to fill in this short questionnaire. And that then helps the physiotherapist or the doctor decide which type of treatment might be most appropriate for that patient.
It's a very simple tool. It just has 9 questions. For each of the questions, the person just agrees or disagrees, and you're able to simply calculate from that the risk category that someone would be allocated to, and that then will inform decision making.
It's very much a patient self-complete 9-item tool. It's very quick for the patient to fill in, very easy. And what we found was the patient would come for their first appointment, physiotherapy appointment, and as they were sitting in the waiting room, they could fill it in very quickly. And then bringing the patient in for their first assessment, we could again very quickly score the tool. And then that tool actually allowed us to guide our assessment and treatment with the patient. And so it's very quick and easy to use.
I thought it was a fairly easy, straightforward questionnaire, really. A typical questionnaire with agree and disagree boxes. So basically I just worked my way through the questions, agreeing or disagreeing with what it said.
The second component is then having matched pathways of care for people according to the risk groups that we can identify. If you know someone's low risk, you know they're likely to do well, they're going to do well with their back problem, so you can reassure them, give them analgesia, send them on their way. But if someone's at medium risk, what we were suggesting is people would require some treatment, conservative treatment, so physiotherapy, perhaps with a chiropractor or an osteopath, something to just push them on and give them that extra little bit of assistance. Whereas if someone's high risk, what the tool does is it particularly identifies people that are fairly distressed and have a lot of concerns about their back problem. And so we're suggesting that you need someone who can address those concerns, as well as all the physical issues that will be going on with their back pain, that you need those two things to go in tandem to actually help those people to move forward and to help them get better. We've been fortunate to be able to test the Start Back tool out and the whole approach of stratified primary care because it was funded by the Arthritis Research UK back in 2007, 3-year randomised control trial. The trial, what it does is it was powered to look at patients that came through to see their GP. We identified anyone who'd had a back problem and we invited them to come to one of 2 clinics. There were back pain clinics that we were running. And at the back pain clinic we then gave patients informed consent, got them to complete a baseline questionnaire which contained the Start Back tool, and then they were randomised through a telephone randomisation process into either receiving usual care, where a decision was made about what to do with them, whether they could self-manage or whether they needed further treatment, referral off to a physiotherapist. That decision was made by clinical intuition in the control arm. Whereas if you were in the targeted treatment arm, under the stratified primary care model, then the patients completed the screening tool, and in addition, they were then advised to get treatment that was matched according to the pathways of whether this individual was low risk, medium risk or high risk.
To develop the low-risk treatment, we undertook a literature review and identified several key guidelines from around the world. A clinical focus group was then used to choose the guidelines which we felt were most appropriate to the prevailing health environment around us. And in this case, it was the European Low Back Pain Guidelines and the NHS clinical summaries. The treatment for the low-risk subgroup involved a brief but thorough clinical assessment to make sure patients didn't have serious pathology, but also to find out their areas of concern, such as the cause of their back pain. Following this, we gave them advice on activity, avoiding bed rest, medication, and issues around returning to work. The oral information was backed up with a written copy of the back book, and we also got each patient to watch a DVD called Get Back Active, which again went through a lot of the issues we'd already discussed.
In developing the treatment package for the medium risk group, we took into account all available evidence about treatment effectiveness and ways and means of improving functional activities and reducing levels of disabilities in that group of people.
And then there's a third small group of people who have more complex problems. So their back pain becomes complicated by their reaction to the pain. Maybe they're very worried about the pain, very fearful about the pain. They might get depressed with the pain. And we think that this third group of people, as well as needing physiotherapy to tackle their physical symptoms, also need help just managing their pain and dealing with their pain on a day-to-day basis.
The high-risk treatment was developed following a review of the current evidence-based guidelines, and we also looked at best practice and opinion or consensus with regards to the physiotherapy management of back pain. We developed and delivered a stepped training and support package to enable physiotherapists to be able to adopt this subgrouping and targeted treatment approach. So the physiotherapists who were trained to manage the low-risk subgroup of patients received a one-day training course. The physiotherapists who were to manage the middle risk subgroup of patients received an additional 2 days training, making a total of 3 days. And the physiotherapists who were trained to manage the high risk subgroup of patients had an additional 6 days on top of the previous 3 days, making a total of 9 days training. We also developed and delivered a support package. The biggest part of this was really some clinical mentoring, and this was provided to the physiotherapists who'd had the middle and the high risk training. It was provided to them separately by different facilitators and consisted of them getting together as a group with the facilitators for 2 hours a month for a 12-month period. And this was really to try and consolidate their knowledge and skills to further develop it and to support them in implementing this approach in clinical practice.
What the trial was showing was that use of the screening tool hugely impacts on the proportions of patients that get sent onward to further physiotherapy. So in the control arm, we were seeing around 59%, I think it was, so roughly 2/3 of people were being sent through, whereas in the targeted arm, we got 75% of people sent through for further treatment, which sounds very high, but because there was far less people that were low risk being sent through, it was actually overall a much more efficient approach to the use of the resources in primary care. But also what's exciting is we were able to look at how the low risk patients did through the stratified targeted model versus the control. We found that there were no differences, despite the fact that when people go through stratified care, the low-risk patients were encouraged to just self-manage. So on the whole, they saw somebody once, whereas around half of the patients that went through the control arm that were low risk were encouraged to go through for treatment, and yet there was no difference at 12 months or 4 months in the outcomes of those patients. And I guess the implications, therefore, from that are, that we would read into that, is that there's a lot of low-risk patients who at the moment are being sent through for treatment but don't actually require the additional help because they were likely to get better anyway. When we looked at the outcomes among the medium risk groups, that's where we saw huge benefits, because the medium risk patients are the largest proportion. They're around half of the patients that came through. And among those people, we were seeing huge differences in their number of days that they were taking off work. So, for example, those that got the targeted care took on average 4 days off work, whereas those in the control package took 18 days off work over the course of a year. So quite a big difference there, which would represent quite a big cost saving to society, were we able to implement this kind of approach across the UK. Among the high-risk group, these are the patients that we know are really at the highest risk of having persistent disabling problems, perhaps having long times off work, even not being able to get back to work because of their back problem. And among that group, we found that in the short term, we were able to have huge impact through giving them stratified primary care model. And that was probably because of two components. One, we were ensuring that all high-risk patients were sent for treatment, whereas we know in the control package, around a third of high-risk patients were just missed. They were left to self-manage their problem. So partly we were seeing outcomes improved because of that, but also our high-risk package that we were delivering with the pathways that we'd developed, specifically trained physiotherapists to give them confidence to help those sorts of people to address the sorts of barriers that were contributing to their back problem.
But the really good news is that the start back approach overall was cheaper than standard care. So not only was it better clinically, there were also savings in terms of the health economic analysis.
The key cost outcomes of the start back trial were that the targeted intervention resulted in an average saving, or cost saving, of £34 over the control intervention. This, at the same time, there was a health benefit, an average health benefit in terms of QALYs, so an average QALY gain for the targeted intervention of 0.039, QALYs being quality adjusted life year gains for the targeted intervention. Health economists tend to look at a benchmark £20,000 per QALY in terms of their decision-making policy. There was a 99% probability that the targeted intervention was cost-effective at that £20,000 per QALY threshold, which reflects the cost-effectiveness of the start-back intervention, the new tool, over the control or the usual care.
We've shown in an experiment, if you like, so in a carefully controlled randomised trial, that the new approach is better than standard care. The next stage of our research has been to take the start-back trial approach and to see whether we can embed this in everyday clinical practice, so working with a whole physiotherapy service, working with a number of GP practices. The stage following from that will be to see whether we can roll this out nationwide or with groups of physiotherapists and GPs outside North Staffordshire, because we believe that this new approach has really important implications for people who are delivering services for people with back pain and people who are commissioning services for people with back pain.